Afternoon, everyone. My name is Dr. Tracy Newman, and I'm the medical director at the North Dakota State University Center for Immunization Research and Education, or CIRE. Today, I have the pleasure to introduce Dr. Paul Carson, who will be presenting this webinar titled "It Starts With Us: Why Healthcare Worker Immunization Matters." Dr. Carson is an infectious disease physician with over 30 years of clinical experience. He is currently an Emeritus Professor of Practice at North Dakota State University of Public Health, where he founded and previously served as the medical director for CIRE. He is also a professor at the University of North Dakota School of Medicine and Health Sciences. He has held many roles within Sanford Health, including chair of the Department of Infectious Diseases, director of clinical research, and chief quality officer. Dr. Carson, welcome. You can begin.
Great. Thank you, Dr. Newman, and welcome everyone to our webinar today on healthcare worker immunization. I kind of took a little liberty in playing with the title of "It Starts With Us." Some people follow this, series. It ends with us. My little play on words here is because we in healthcare are on the front lines of vaccination in a number of different ways. We're often asked by our family and friends for advice. We are often giving advice or giving vaccines to our patients, and then we are confronted with being exposed and potentially transmitting a number of infectious diseases in the workplace. And so we ourselves are on the front lines of questions about if, when, how, and the necessity of vaccines for ourselves. So I want to walk through some of this for all of you today. Now, first, to start off, I have no relevant financial relationships or conflicts of interest to disclose. We don't take any grants from pharma or industry, and so there's no potential conflicts. The learning objectives that I hope to cover today are to go through the current CDC recommended immunizations for healthcare workers. I want to explain the importance of healthcare worker vaccination in reducing disease transmission, why it's important for protecting our vulnerable patients and maintaining a healthy workforce. And then I want to identify the potential benefits and challenges of implementing vaccine mandates for healthcare workers, something that raised a lot of controversy, particularly during and in the wake of the COVID pandemic. So first, I want to give kind of an illustrative case. And I hope if there's anybody here that in particular is in administration, or if you're a director of nursing or in charge of a facility anyway, think about this outbreak in Tucson. This isn't even in the current issue with the outbreak that stemmed from Texas, and what this can mean for healthcare institutions. So this was a published outbreak that started with an index case of a woman who had traveled abroad. 37-year-old woman who traveled abroad. She was unvaccinated for measles, apparently got exposed in her travel, brought that back to her home in Tucson, Arizona. Later was discovered to have measles, but I'll get into that in a minute. But in retrospect, along the way, she exposed 145 airline passengers, about 1,700 patients in a healthcare system, and a little over 1,700 healthcare providers, in large part because her infection wasn't recognized as measles initially, which is often a problem. So people can be infectious for about 4 days prior to their measles infection, and prior to their rash, and for about 4 days after their rash. And a lot of times the rash isn't recognized as measles. And so she went essentially undetected, presenting to emergency room and healthcare, exposing many, many people to this airborne virus. She then, presented to this hospital where she infected, I believe it was in the emergency room in Hospital A, infected a 50-year-old unvaccinated person, who then went on to expose a number of other people, including a nurse, a healthcare worker, a nurse who had been unvaccinated. And this nurse, a 41-year-old nurse, went on to expose 2 household contacts and about 541 patients. 2 of those led to subsequent measles cases, one in that person's home and another individual case in that hospital, but 541 people exposed. All told, this index case that was initially unrecognized and missed, which is unfortunately not at all uncommon when it comes to measles. This index case and most of the next generation cases weren't suspected. It led to a total of 14 cases, which might not sound like a lot, although a number of these people were hospitalized and sick. Most of these cases were acquired in the healthcare facilities where they were exposed. This led to 8,231 contact investigations conducted for those 14 patients. 58% of those were healthcare facility exposures, and it required the rapid review of almost 15,000 healthcare providers at 7 hospitals and the emergency vaccination of about 4,500 healthcare providers, about 30% of that healthcare workforce that lacked documentation of adequate immunity. So it's just a massive management undertaking to try and assure no further spread of this outbreak. The 2 main hospitals that were involved spent back at that time in 2008 about $800,000, which is about $1.2 million today, responding to and containing that measles cases. This is why Louis Pasteur, he probably couldn't foresee these sort of hospital outbreaks, but his wisdom still pertains today. When he said, kind of the father of microbiology and one of the leaders in vaccinology, said, when meditating over disease, I never think of finding a remedy for it, but instead a means of preventing it. Well, a little knowledge check. We're going to do a few questions along the way. We're not going to have you answer in the chat or anything. Just think about this for yourself and see how you would answer, and then kind of compare that after we kind of do the training today. So which of the following vaccines is currently recommended by the CDC for all healthcare workers? Hepatitis B, measles, mumps, rubella, varicella, or the chickenpox vaccine, or D, all of the above? Like a lot of our multiple choice questions, all of the above is often a good choice when you're not sure. So all these are recommended. In fact, those and some more. This is the adult immunization schedule, but several vaccines are particularly, recommended for healthcare workers. COVID-19 vaccine, influenza vaccine, a Tdap booster, measles, mumps, rubella immunization, chickenpox immunization, hepatitis B, and meningococcal vaccine for certain healthcare workers, people who work in the laboratory setting that might be exposed to cultures of Neisseria meningitidis. So we're going to focus on these ones in the boxes without the meningococcal, since that's only really select personnel. The last formal complete guidance issued from the CDC, the Advisory Committee on Immunization Practice, was back in 2011. I wasn't able to find an update for all recommended vaccines, although some individual ones have had some caveats and changes. And of course, COVID was new since this guidance went out, but we'll be referring still back to this in a large way. So first of all, we have to kind of think about who is a healthcare personnel or a healthcare worker. The way the CDC defines this is that healthcare personnel are all paid and unpaid persons working in the healthcare settings who have the potential for exposure to patients and/or infectious materials, including body substances, contaminated medical supplies and equipment, contaminated environmental surfaces, or contaminated air. So this isn't going to be everybody in your healthcare setting, but it is going to be more expansive than the people we think of, traditionally working face-to-face with patients. So for example, nurses, doctors, therapists, et cetera, are going to be obvious, but even like our environmental staff and dietary staff and so on are potential healthcare personnel under this definition. So the ACIP recommends for healthcare personnel that an employer must consider the nature of the employment. So what is it that they do? Are they exposed to these? Are they exposed to patients, to surfaces, to patient environments? What's the likelihood of exposure to vaccine preventable diseases and potential consequences of not vaccinating susceptible healthcare personnel? What are the characteristics of the patient and resident population the facility serves, and how likely they are to have vaccine preventable diseases? So not all facilities are going to be the same. And then the risks and consequences of an infected healthcare provider transmitting a vaccine preventable disease to patients. So this is the list of the vaccines that I just mentioned, with the typical schedule Hepatitis B being typically a 3-dose schedule. There's a 2-dose option. We'll go into more detail in a minute. Annual flu vaccine, 2 doses of the measles vaccine, 2 doses of mumps, 1 dose of rubella, which in effect is going to mean 2 doses since the only vaccine available in the US is a combination of those 3, measles, mumps, rubella. Tetanus, diphtheria, and acellular pertussis, the Tdap, is a 1 dose per lifetime booster. Varicella zoster vaccine, not the chickenpox one, but the actual varicella zoster virus. So that's the chickenpox virus. 2-dose vaccine series or past infection with chickenpox, which we'll get to in a minute. And then the COVID-19 vaccine, at least 1 dose, and then seasonal updates are recommended for healthcare workers. Now, next kind of knowledge check question to kind of think about in your mind. Actually, this one I'm just giving you the answer. Are there any federal or state requirements for immunization of the healthcare provider? There are no federal requirements that healthcare personnel be immune to or receive immunization for any vaccine preventable disease. So it's not at the federal level. There may be state or local requirements. To my knowledge, there are none in North Dakota. However, as many of you well know, many, and in fact, probably most of our healthcare facilities will require immunity or immunization for specific vaccine preventable diseases as a condition of employment. Most often, this is going to be proof of immunity or history of vaccination to measles, mumps, rubella, hepatitis B, varicella or chickenpox, and some facilities for influenza and COVID-19 vaccines. There is one federal regulatory requirement, and that comes from OSHA, the agency that is charged with protecting employee health and oversight of employee health. So the only vaccine addressed by federal OSHA is the hepatitis B vaccine in the bloodborne pathogen standard. And per OSHA, employers are required to at least offer hepatitis B vaccine to susceptible employees who may be exposed to blood or other potentially infectious materials as part of their job. So the vaccine is not required, but it is required that the facility offer it to their employees. If the vaccine is declined, OSHA says that the facility must have a declination form that is signed by the employee, proving that they were offered this and declined. All right, so let's talk about that first vaccine, hepatitis B. So, we in healthcare, that work in direct patient care and in healthcare environments know that needle stick injuries are part of our job hazard. And in fact, if you look at the incidence of needle stick injuries in healthcare workers, this was the incidence per 100 occupied beds. So this would be, I think, annual incidence per 100 occupied beds. It's about 30 to 40 needle stick injuries, in the mid 90s, early 2000 per 100 occupied beds per year. The Needle Stick Safety and Prevention Act was passed, which required healthcare facilities to put in a number of mitigation measures to try and decrease the exposure to needle stick injuries that we may be exposed to as healthcare workers. And it did have a significant effect. It dropped those rates by 10 to 20 per 100 occupied beds. And that's kind of where we've sat for quite some time. So we got some improvement there. But if you look at the risk of getting infected, so this is seroconversion, this means you got infected, you made an antibody response to the various bloodborne pathogens that are out there. Hepatitis B is by far the biggest risk to us. So if you look at that compared to like HIV and hepatitis C, the risk of you becoming infected from a needle stick that contained blood from an HIV positive patient is about 0.3%, or about 3 out of 1,000. Hepatitis C is about 2 to 3, and hepatitis B is about 30. We used to call this the rule of threes, 0.3, this says 2, but 3 and 30. So about a 10-fold increase from HIV to hepatitis C to hepatitis B. And if that source patient is both hepatitis B surface antigen positive, that indicates active infection, and E antigen positive, which means they have a more highly transmissible form of the virus, more aggressive form of the virus, there you got a 50% chance of seroconverting or being infected. This is if you're not immune in the first place. So hepatitis B was and still is to some extent, a very substantial risk for those of us in healthcare that may, especially if we may be exposed to needle stick injuries. And in fact, if you looked at high-risk categories in the past, what's your essentially lifetime risk of becoming infected with hepatitis B, or at least seroconverting and being antibody positive to hepatitis B? By far the biggest risk is injection drug users. So their kind of 3, 6, 9, 10-year risk is almost 90%. Now this is from the past, really prior to widespread hepatitis B immunization. And you can see, homosexual men were, 40, 50, 60%. But kind of go down here to healthcare workers. If you were a healthcare worker, prior to our widespread vaccine programs for hepatitis B, you had a lifetime risk of, approaching 20% of healthcare workers would be seropositive for hepatitis B because of, most of the time, exposure and infection in the workplace. Pretty substantial lifetime risk. That risk has gone down dramatically because of our widespread vaccine programs to prevent hepatitis B. We started immunizing infants to mothers infected with hepatitis B back in the mid-'80s. Started testing all pregnant women to try and increase that net of capturing women who might be infected with hepatitis B. Then it was just recommended to immunize all infants. It added all 0 to 18-year-olds in 2000, and then widespread newborn immunization recommended by the ACIP as part of an hepatitis B elimination campaign. The goal is to actually eliminate hepatitis B from the United States. That kind of got launched in 2005 and 2006, and we can see just steady decline of the number of acute hepatitis B cases in the United States since that time. So these healthcare workers are much less exposed than we were in the past, because the population at large is getting more and more immunized. Now, what's the vaccine that's recommended for all people and us as healthcare workers? So recommended for any healthcare worker with potential exposure to blood or body fluid. The composition of this vaccine is a recombinant hepatitis B surface antigen. So they use molecular techniques to basically recreate one protein on the surface of the hepatitis B virus. It's not the virus. It's not a live vaccine. You can't get hepatitis B from it. It's a fabricated, if you will, hepatitis B antigen or protein from that. One form of the vaccine also has the option of adding an adjuvant, which makes the immune response a little stronger. Efficacy for this is about 90%, 92% in healthcare workers under the age of 40. Goes down a little bit if you're over the age of 40. So age is one of the risk factors for not getting as good a response. Duration of immunity, we're going to go over this in a bit more detail, but about 75% of healthcare workers will have antibodies present in their blood 10 to 31 years after immunization. We'll go into that, what that means in a little more detail here in a second. Typical schedule is 3 doses of the vaccine given at 0, 1, and 6 months. Minimal interval of 4 weeks between doses 1 and 2, and a minimum interval of 8 weeks between dose 2 and 3, and a minimum of 16 weeks between 1 and 3. So just FYI, that you can have some issues with going too short of an interval. You might actually have to get another dose if you go too short. There's not really an issue if you go too long. So let's say you missed that second dose and it's been a couple months or 3 months or even 6 months. You can still give that second dose and it's fine. You don't have to repeat any doses. So if the duration is stretched out, that's not a problem. And then the one product that has an adjuvant in it is called Heplisav. That actually can be just a 2-dose series at 0 and 1 month. And it's more expensive, but it induces a stronger immune response because of the adjuvant. Now, one of the issues that comes up is, who got adequate protection from the vaccine and who didn't. If we measure antibodies, the level of antibody that to hepatitis B surface antigen, so it's called anti-hepatitis B surface antibody, that's considered protective is greater than 10 milli-international units per mil of blood. So level of 10 or more. The problem here is that levels of antibodies decline over time and they decline more quickly if you were immunized as an infant. We're going to get more into that in a second. We also know that if you were an initial responder, so let's say you got a response, if we actually measured it, a month after you were vaccinated, as an example, even if it later falls over time, essentially everyone that, if they did get an initial response, will get what's called an anamnestic response, a memory response to the if you're exposed to the virus. So you'll be protected. But the problem is we don't test routinely after vaccination to know if you were an initial responder. So if you don't have those protective levels of antibodies, we can't say if you responded and then just sort of declined, or if you never responded. So we have to think about that a little bit further. So it is recommended now that we do routine testing for newly vaccinated healthcare personnel. They should be tested for immunity 1 to 2 months after completion of the 3-dose series. And we should consider revaccinating them if they had an inadequate response. If they didn't mount an antibody response to that vaccine, we give another series. If, like many of us, we were vaccinated but don't know if we got a prior response, you have a couple of options. You can, if the healthcare system is willing, cost them money. Sometimes they're not willing to put out this much, but some will. You can say, look, we're going to measure the antibody status of all of our employees, and we're going to boost them if it's less than 10, and recheck a titer after 1 to 2 months and see if they responded to that booster. And if it's still low, we basically do a new vaccine series with the adjuvanted vaccine, the more potent one, the Heplisav. An alternative, and a lot of healthcare institutions do this, is to say, look, that's too big of an undertaking to test all of our employees. We will test if there was a bloodborne pathogen exposure. So if you got a needle stick injury or some other bloodborne pathogen exposure, we'll test you then. If you're less than 10, you can't just get a booster because the risk from that exposure is present and real, and giving a booster dose may not get you a high enough level fast enough. So you have to get what's called HBIG, hepatitis B immune globulin. So you're given a dose of antibodies against hepatitis B and then get a booster dose if you had a high risk exposure. That's if it's like you can test the source patient and you know that they had hepatitis B. If the source is unknown or low risk, you can just give a booster dose. But for the high risk ones, we're going to give HBIG and a booster. This is, you're going to get these slides if you want as a handout. This is just an algorithm that takes you through what I just said with a little bit more detail that you can refer back to. I'm not going to walk through this, but it kind of goes through, the different antibody levels and testing and what you do for vaccine doses. All right, just to kind of bring this home a little bit more, is to kind of point out that, like, a lot of you on this webinar here may have been vaccinated as an infant. So the recommendation for universal infant hepatitis B vaccination in the US was made in 1991. And the vaccine was recommended for all unvaccinated children in 1997. So that's a lot of people kind of in the early middle of their career in healthcare. And so a lot of people in this cohort here are now in the workforce. And you probably did not get tested after your infant immunization for hepatitis B. So you don't know if you have antibodies to that infant vaccine. This was a study that looked at that sort of scenario. They did this in medical students. So they looked at 875 medical students who had been immunized as an infant and said, hey, let's take a look and see how many of them are immune. And they found 516 of those had adequate levels of antibody right out of the chute. So these are medical students that are probably, in their 20s or 30s. But they found that 41% did not have detectable or adequate levels of antibody. About 359 of the students, so about 41%. All of those students said they would accept a booster as part of the study, so they got a booster dose. They lost 8 of them to follow-up, but then 351 then agreed to do further serologic testing. And they found that of that 351, 84% mounted a good response with that booster. They probably had a good initial response and would have been fine either way. But 16% or 57 of those students did not boost, and they were advised to complete a 3-dose second vaccine schedule, or I would probably recommend the 2-dose Heplisav, the adjuvanted vaccine. So all told, 92% of this medical student group immunized in infancy had either adequate antibodies right out of the chute or mounted adequate antibodies with a booster dose, one booster dose, which means they probably were immune in the first place and had that memory response or anamnestic response. Hopefully that's clear. I'm happy to take questions on that if that's a little confusing. Risk factors for initial poor vaccine response. I mentioned one of these already, age over 40. Also male gender, smokers, obesity, and of course immunodeficiency are all considered risk factors for an initial poor vaccine response. If these people, we recommend testing for immune response for everyone, but especially these people that are higher risk. If they are a non-responder after a traditional 3-dose vaccine series, they should get a reattempted vaccination with a second series, preferably the Heplisav adjuvanted hepatitis B vaccine. If they are still non-responders, they have to be treated as susceptible to hepatitis B should they be exposed, and they would be eligible to get hepatitis B immune globulin with a high-risk exposure. All right. Oops, something happened with one of my slides kind of got goofed up here. We're going to talk about measles now. So measles is transmitted via the airborne route and is thought to be one of the most infectious communicable diseases known to man. The R0 or reproductive number, which is a measure of how many cases are likely to be generated from a single index case in a susceptible population. So one case of measles introduced into a susceptible population would typically generate an additional 12 to 18 cases. That is one of the most, if not the most, infectious virus in humans. Transmission in the healthcare setting is well documented. Healthcare providers have been infected in recent measles outbreaks. And it's still endemic in much of the world outside of the North and South America. Just to backtrack on that last slide, measles is an airborne spread virus. So people can breathe this out in the air. It can stay suspended in the air for up to even a few hours after a person's in a room. So even after they leave the room, it can linger and be transmitted to other people. All right, so now we obviously know measles has kind of hit the US, and North Dakota's had its first reported case of measles since 2011. We are on track here in 2025 to surpass our last worst year in 2019. I think we're going to go way above this by the time this year is over. And if you kind of look at where all the cases are, North Dakota was 5th highest here, I don't know, as of about a week ago for overall number of cases, and we were number 1 per capita. So if you kind of go cases per population, we're the worst. I don't know if we're still at 34 cases or thereabouts. It might be more now, but it's right around there. And if you look even at this recent outbreak in Texas, healthcare facilities had issues. One of the issues in one of the hospitals was that a newborn nursery had a bunch of newborn babies exposed to measles in a West Texas hospital, and they had to give these babies, I believe, some kind of measles immune globulin to try and fight the virus. So because they're not protected, so terrible situation. We can have presumptive immunity, evidence of immunity to measles, and here's the different acceptable criteria for that. Written documentation of a 2-dose vaccine series of live measles virus. A lot of us will have, like especially my age, you're going to have a hard time digging that up. But if you've got written documentation or you can access that, that's proof of 2 doses of the vaccine. Or laboratory evidence of immunity, you get an antibody titer drawn, and if you have IgG antibodies present in your blood, you're considered immune. Or laboratory confirmation of disease. So like, if it's not enough to say, oh, my mom told me I had measles as a kid, it would need to be that you had measles and you went to the doctor and you had laboratory testing and confirmed it, and you can show that laboratory test. So kind of a hard criteria to meet. Or if you were born before 1957, it's kind of almost every child before 1957 was infected with measles And so that's kind of presumptive immunity. I have a little caveat on that in red here. Although most people born before 57 will be immune, about 2 to 9% won't be. And healthcare facilities should consider at least vaccinating healthcare personnel born before 1957 who lack evidence of measles immunity. You might still want to test them to see if they have measles immunity. Mumps, rubella, and varicella also are considerations. Varicella is another airborne spread virus. Mumps and rubella are spread by droplets, so not as infectious. Presumption of immunity is similar with measles, particularly on these others. Documentation of 2 doses of live virus vaccine. 1 dose is considered adequate for rubella. Laboratory evidence of immunity, IgG antibodies, laboratory confirmation of disease. Here, chickenpox, a doctor interview is okay. If your doctor says, yeah, I saw this person, they had chickenpox, that's okay. You don't need definitive laboratory evidence. And again, birth before 1957 for rubella and mumps, not for varicella. Varicella, there is a slight concern of the ability to spread the vaccine form of the virus. So varicella is a live vaccine, not the shingle shot, but the actual chickenpox shot. So the varicella virus vaccine. This induces a sort of attenuated infection to induce immunity. And rarely there has been documentation of like a localized chickenpox-like rash at the injection site. The risk of transmission from this is low, but it has been documented after exposure to persons with a vaccine rash in households and in long-term care facilities. To date, I don't believe there's any known transmissions documented after vaccination of a healthcare provider. But we need to consider precautions for a healthcare provider in whom a vaccine rash occurs after vaccination. So something to watch for if you were to develop this sort of localized vesicular rash. This healthcare provider should avoid contact with persons without evidence of immunity at risk for severe disease and complications until all of those lesions have resolved and are crusted over or fade away and no new lesions appear in a 24-hour period. Varicella is another one, airborne. You can just have nightmare scenarios in a healthcare setting where you have a healthcare worker that comes down with chickenpox and exposes a bunch of people. It's just, I've had that happen when I was the director of infection control and one of my past jobs, and it was really a nightmare. All right, we're going to switch over to pertussis. So pertussis used to be a very ubiquitous infection, so whooping cough. Hundreds of thousands of cases every year in the United States, particularly an issue for babies, which are much more susceptible to severe illness and even death. The whole cell pertussis vaccine became available in the early 1950s. Incidence of disease went way down. There were some problems with that vaccine. It was very reactogenic. It caused a lot of irritability in infants, and it got replaced with an acellular pertussis vaccine in the 80s, which it's not as good a vaccine, unfortunately. And so we've had kind of some resurgence, not anywhere near what we had in the pre-vaccine era, but we are seeing cases, and this year is looking, and last year are looking like real bad years for pertussis. It tends to come in cycles. And, we had an outbreak in North Dakota last year. There's concern that this year might be pretty rough as well. I'm not going to show these videos, but I highly encourage you to go back and look at, pull up on your YouTube these couple of videos. One, if you searched YouTube and just said infant girl with whooping cough, this is the actual website if you go back to look at the slides. And the other one is Layla's coughing spells, pertussis, whooping cough despite vaccination. She got the acellular pertussis had worn off in her. But take a look at these videos and see just what pertussis can do to particularly an infant and a young child. I mean, it's hard to watch. It's very, very hard to watch. I make my students in infectious disease epidemiology watch these videos, and they're tough. And this can be really, really hard on kids. So the new normal of pertussis in the United States is that we got rising incidence again since the 1980s, especially in infants. We tend to have cyclical outbreaks with peaks about every 3 to 5 years. For example, in 2014, California had an epidemic with over 11,000 cases. Immunity via the vaccine or disease wanes over time, and acellular pertussis vaccines, almost exclusively used since 1997, are just not as good as the old whole cell vaccine, but that had a lot of side effects, and so we're kind of stuck with this one. There are some new ones in the pipeline that look like they might be better, but they are not FDA approved yet. Most of us as adults are susceptible to pertussis. Our immunity from our prior vaccines wanes. Very few of us have had a Tdap booster. We may be up to date on our tetanus booster. That's the big T. The little d, little AP means a smaller amount of those antigens in the vaccines. The booster, you don't get as big a dose as when you get the primary series. So the Tdap is a smaller amount, little d, little AP, that's why it's in the lowercase letters, is recommended at least once for every adult in their lifetime. But a lot of us haven't had that. Those who have received it are likely to be susceptible again within a few years, unfortunately, but it does offer some protection. Until there's a better pertussis vaccine, the incidence likely to stay high and epidemics will occur every few years. What's the ACPI recommendations on this? So the Tdap, again, that's the booster, the little d, little AP, was licensed in 2005 and has been recommended for healthcare personnel with direct patient contact since 2006. Again, this has reduced antigen levels for the diphtheria and the pertussis. It's also recommended regardless of age that healthcare personnel without documentation of a Tdap immunization should receive it. There's no minimum interval between the last dose of a tetanus booster and getting that Tdap booster. Only one dose of Tdap is currently recommended. That could change because we do know immunity to this doesn't last real long. It's usually a few years. But at present, only one dose is still recommended for healthcare personnel, other than for pregnant women who are recommended to receive Tdap in the 3rd trimester every pregnancy. This is so that mom makes antibodies, booster level antibodies, passes those through the placenta to her baby so that the baby gets about 6 months of protection against pertussis when they are by far the most vulnerable to very serious illness and death. All right. I kind of want to finish off with a discussion about vaccine mandates, which really polarized, I think, a lot of people in healthcare during the COVID pandemic. We saw, protests of lots of people, but a lot of healthcare personnel, nurses and others, that really felt this was an overreach to mandate COVID vaccines. And COVID certainly had some unique aspects to it, given its newness and so on. To be fair, vaccine mandates, which we've had vaccine mandates for school, for your child to enter school, and all of us going to school, we had to have proof of vaccination to enter school. Healthcare facilities have had vaccine mandates for decades, both hepatitis B, MMR. Many facilities have chosen to do flu vaccine mandates. COVID kind of put people over the edge, and I think we have to recognize that mandates are a very blunt force instrument to try and achieve a goal that we can kind of discuss or debate about whether that's an appropriate goal or not. But I think healthcare systems and certainly public health entities saw that when these vaccine mandates are put in place, these need to be used very judiciously because it polarizes people, as we kind of saw. And I think what we have to recognize is that there are competing goods, both valid goods that are at odds with these things. So on the one hand, with trying to get a highly vaccinated population, say a highly vaccinated healthcare workforce, we've got issues around the common good that we're trying to protect each other. We're trying to protect our patients. This is sort of solidarity, public health goals, but this often may be in direct competition with other things we value, like personal liberty, individual choice, what often now is being called medical freedom, bodily autonomy. I get to say what goes into my own body. I'll try and kind of walk through why this may be a consideration, and we may get some discussion on this. But I'll kind of walk through some of the logic on this. John Stuart Mill was a British philosopher who had the statement that I think maybe has some applicability here. He says the only purpose for which power can be rightfully exercised over any member of a civilized community against his will is to prevent harm to others. Now, I think all of us would agree we want to prevent harm to others. There may be debate about what vaccines and vaccine mandates accomplish here, but that general principle, I think, sort of underlies at least the thinking or attempted justification of this. Just a brief bit of the history on this. There's the legality of mandates. There's long-standing precedent for government mandates on vaccines. First big challenge on this was with the smallpox vaccine. There was an outbreak in Boston. Boston public health officials mandated smallpox immunization for the municipal population of Boston. A person named Jacobson objected to this, did not want to take the vaccine. It went all the way up to the Supreme Court, and the Supreme Court validated that public health authorities had the right, in the interest of protecting other people in the public, to require smallpox vaccination. This eventually gave way to smallpox vaccine being required for schools, and then other vaccines came in the mix, like measles, mumps, rubella, polio, etc. And so school entry mandates for immunization really were adopted by every single state. Every state has school vaccine requirements. And then there's laws about what's called employer precedent, that what's called the doctrine of employment at will, that basically employers have the right to set standards for working in that workplace. You as a potential employee can choose whether you want to work there or not, given those conditions. There are some exceptions to this with collective bargaining agreements, like, for example, with nurses' unions over what vaccines can be required or not. So they may collectively bargain, for less requirements, as an example. This has now been, some of this has been challenged recently. There was a new Texas law that was passed that prohibits COVID-19 vaccine mandates by private employers. So they challenged that, employment at will precedent, and saying, at least for this one vaccine, you employers can't require your workforce to make them have that. And so that's an interesting kind of flip on that, about that it's particular to one vaccine and not a general principle. Idaho recently passed what they called a medical freedom bill that would ban vaccine, medical diagnosis, or treatment requirements by Idaho businesses, schools, and governments. So they have now set the precedent that schools and other businesses, I think this would, I'm not sure if this includes healthcare facilities, but I think it does, can't require this. So some states, I think, kind of feeling what the polarization that was felt during COVID, have pushed back on this. So we're in a different kind of legal landscape now. All right. Little knowledge check. Ask yourself here, true or false. The CDC has the legal authority to mandate vaccines for all healthcare workers in the United States. True or false? Hopefully you know that that's false. CDC actually doesn't have any authority to sort of make anybody do anything. It's a guidance body. It makes recommendations, and often policies may follow. Previously, their guidance may require, under the Affordable Care Act, to require insurance carriers to pay for vaccines if they were ACIP or CDC recommended. All right. I'm going to try and make maybe the case, and I'd say this is somewhat on a limited basis, but I'm going to try and make the case for why mandatory healthcare worker immunization could be considered by healthcare facilities. And I'll use, I think, the two of the most controversial vaccines, influenza and COVID, as the example here. So are there unique considerations for healthcare workers? I think a lot of people would agree, sort of mandating these kinds of vaccines in other businesses, like happened for a period of time in the United States, was probably not a good idea. A lot of that stemmed from the fact that COVID vaccine turned out to be not that efficacious of a vaccine at preventing infection. Still pretty good for preventing serious disease, but was not very good at preventing infection and possibly transmission. Use on kind of widespread scale out in the community, with mandates. And under the Biden administration, we briefly had a time for, widespread mandates that got challenged and struck down. But healthcare institutions still had the right to require those for workers. And are there unique considerations for those of us in healthcare? I think so. So first of all, I think we have to recognize that a lot of the good about vaccines isn't just about my individual choice of protecting myself or not protecting myself. It's that vaccines, depending on the vaccine, depending on which kind, operate not only at the individual level, but also operate at the sort of population level with what we call herd immunity or herd protection. Not all vaccines do this equally by any means. And I'm going to talk about two of them that don't do it as well, influenza and COVID. But I think we need to recognize that part of the reason for wanting population level immunity is because a number of individuals in the population aren't going to benefit from a vaccine or aren't going to respond to a vaccine. And they essentially rely on the rest of us to kind of protect them from being exposed to these pathogens. The elderly often don't mount a very good response. I'm going to show you some data on this in a second. Infants and the immunosuppressed often do not. And not everybody responds to a vaccine. So no vaccine's 100%. What about that kid that just didn't respond? Even, a really good vaccine like measles, for example, gets you somewhere between 94% or 93, 94% with one dose, about 97, maybe 98% with two doses, but there's still 1, 2, 3% of people that aren't going to respond. And so they got to rely on the rest of us to kind of make a wall so that pathogen cannot spread. So I want to go through some inconvenient facts to think about this, when we're trying to balance these competing goods. So fact number one, U.S. population is not very good at getting the flu vaccine, worse about getting the COVID vaccine, and healthcare workers are only a little bit better. And facility mandates definitely increase rates. It may come at a cost, of healthcare workers who are very unhappy. And then what are you going to do with those healthcare workers that, don't want this or don't comply, which can make some real thorny issues between that employee and the employer. CDC, going to the flu vaccine, the CDC recommends since 1981, all healthcare workers receive an annual influenza immunization. Since that time, I was part of these as director of infection control and in the facilities I worked in. We would put out massive efforts to try and persuade our employees to take the annual flu vaccine. So clinics and hospitals would put out these big efforts to educate, encourage, beg, plead, cajole workers to get vaccinated. We'd have our influenza blitzes. We'd have what we call drive-by shootings. You push the cart through the halls of the hospital or the nursing home or the facility. Hey, you want to get your flu shot? We'll do it right here. Easy peasy. Education, talks, etc. I'll go through this table here in 1 second. This was a study that looked at all these different types of strategies to try and boost healthcare worker uptake of influenza immunization. In this column, this was the pre-intervention immunization rate in all these different studies for flu vaccine. You can see like 8%, 13%, 71%. That was one of the best. 30%, 43%. If you kind of look at a few of the things that we used to do, education and promotion, drive-by shootings with the mobile cart, raffle incentives, education letter from leadership, on-site expert education, and probably the most potent declination form. Okay, you can decline, but you got to sign a form saying, I understand why I'm not getting this and all that. You can see it would bring these rates that were pretty abysmal to not very much better. At best, they got up to about 65% with declination forms. Still, you're down in the 37, 46, 49, 39, 22% rate. I mean, just not very good. Contrast that with mandatory vaccination policies. I mean, that got your rates up. So Virginia Mason and Barnes Jewish Christian healthcare systems, big healthcare systems in the South, sat at 30, 71%, got it up to 98, 98%. So they work. Comes at a cost, but they work. If you look at uptake of influenza vaccination in healthcare workers from about 2010 up to a little more recent here, 2018, 2019, you can kind of see that the rates were down there, depending on whether it's a hospital or a clinic or a long-term care facility. Long-term care, one of the most vulnerable resident populations, usually at the bottom here. but 50, 60, maybe at best 70%, and it's up now in 2018. And that's mainly because of the handful of facilities that have agreed to mandate it, to mandate influenza vaccine. That's the main reason pushing this average up. If you look at COVID-19 vaccine uptake in healthcare facility personnel, so this is what percent of healthcare facility personnel took a booster dose, if you will, or an updated seasonal dose of the COVID-19 vaccine in the last season, 2023 to 2024. Acute care hospitals were about 15%, and nursing homes only a little above 10%. So like nobody's having it. People just are not healthcare workers are not having it. If you look at prior studies that looked at why healthcare workers don't get immunized, this was with the flu vaccine. Kind of the biggest one down here. I don't think the vaccines work, over 30%. Vaccine makes me feel unwell. I don't think I'm at risk for influenza. And then, stuff that like vaccine wasn't offered to me, that one shouldn't be a reason. I think needle phobia, which is sitting here at about, just a little under 10%. It's probably higher than that. I think more people are needle phobic than we realize. But kind of this thing about the vaccines don't work often is out there, and we know. I mean, we saw most of us got COVID and had the vaccine. So and flu, we get our respiratory infections during the winter season, and there's a kernel of truth in that, and some inaccuracies in that as well. I'll get to that in a second here. Second inconvenient fact here is that influenza and COVID are killer viruses. We may not think of them that way, but they are. It kills a specific population typically, but it kills. So if you look at influenza in perspective here, influenza kills on average, about 36,000 people a year. That's predominantly the elderly and people with, significant comorbid illnesses, people that we hang around with on a daily basis in healthcare. Contrast that with other things that we might think about much more worrisomely. AIDS, kills about 14,000 a year. The Afghanistan conflict, 2,300 people. West Nile virus, this is, I need to update this, but it's probably closer to 2,500 people or so, or 3,000 maybe by this point, but 10 years ago it was 1,800. The original SARS, not SARS-CoV-2, but the original SARS when was that, in the 80s, only killed 775 people. Kind of freaked everybody out, but only killed that many. And we kind of shrug our shoulders and almost yawn about influenza, but it kills, that's on average. You can have a bad flu season that kills 60, 70, 80,000 people in a year. And morbidity is more. It'll hospitalize about 200,000 people per year. Influenza mortality, annual mortality is about the same as breast cancer. It's related to about 1 out of 20 deaths among Americans over the age of 65. About 1 out of 10,000 Americans will die of influenza this winter. And an estimated direct cost to the healthcare system, this is probably needs to be updated, but $3 to $5 billion. It's very costly. And it, again, disproportionately affects the elderly, the very young. So infants are more prone to more severe disease, and those with chronic diseases, exactly those people that we hang out with all day long. If we contrast that with COVID, so here, I just gave you those stats on influenza deaths. These little yellow bumps here are seasonal influenza deaths by week. So, these are the winter months here. Influenza disappeared during COVID because nobody was going out. We were wearing masks, all this stuff. Turns out that, social distancing and masking works really well for flu. Maybe didn't do as much as we'd ever hoped for COVID, but it worked really well for flu. Influenza back here, this is those red kind of bumps. You can see that's how many killed, but look how much more death per week was from COVID. Even getting out to, kind of the last flu season here, COVID killed probably twice as many during the winter, and then also kills in the summer. The hazard ratio, so likelihood of a bad thing happening, for in-hospital mortality. So what's the probability you'll die in the hospital from influenza if you're hospitalized in the hospital versus if you get hospitalized for COVID? You got about a 35% higher chance of dying if you're hospitalized from COVID than if you were hospitalized for influenza. So it's probably a little worse than influenza. in part because it can be a bit more serious, and secondly, because it's more contagious. We just still get significantly more cases of COVID than we do of influenza. And this is looking at hospitalization rates. So the blue here is influenza. This is hospitalizations per 100,000 population. So you can see typical flu years went away during that 2021 and 2022. Back again, massive numbers of hospitalizations from COVID during the worst of the pandemic. But even now, like 2024, hospitalizations are about the same during the flu season, but it's also hospitalizing people in the summer. So we get more hospitalizations from COVID than we do from influenza. Here's the other problem, is that healthcare workers frequently get influenza and COVID-19, and we spread it to our patients. There's been a number of studies on this. I'll kind of move through these quickly, but in a cross-sectional study of house staff or residents, they found that 37% of these residents working in a hospital had an influenza-like illness during the prior 8-month period. 9% had more than one illness. Illness lasted on average about 7 days, and they missed work an average of about 0.7 days. What they concluded in this study was influenza-like illness was common in healthy resident physicians, and most continued to work most of the days of their symptoms. And if you look at the same sort of thing for nurses, you look at the same sort of thing for other healthcare personnel, that's what we do. We don't stay home because we don't want to burden our coworkers. We think we're kind of okay, and we bring our snuffles and our coughs and what may feel like a cold to us, but may be actually influenza or COVID. We bring it into the workplace. Here's a NICU study. They looked at staff immunization rates for influenza, pretty abysmal. This was back in the 90s, but only 15 to 20% of this NICU staff were immunized for influenza. 76% of those employees reported a flu-like symptoms during the study period and continued to care for patients. Here's a study in France where they looked at hospital-acquired influenza and your likelihood of getting that influenza in the hospital from another sick patient. If you're exposed to a sick patient, you're about 4.8-fold higher risk of getting hospital-acquired influenza. But if you were exposed to a healthcare worker, you had a 12-fold higher risk of getting influenza. It's probably because that healthcare worker is in our face, in the patient's face, bathing them, feeding them, helping them, administering treatments, and so on. Just much more intimate contact. Here's another interesting fact here that I think is I'm going to skip this one because that's kind of saying the same. This is the one I wanted to mention. This is a German study of 122 patients with newly diagnosed influenza. They followed these people and their household contacts daily with PCR tests to look for a virus. What did they find? They found 21% of adults acquired infection by culture or PCR. So these are the household contacts. 21% got evidence of infection and never developed symptoms. So of those household contacts, that got infected, 21% of them never had symptoms. 30% of the secondary cases had high viral loads on the day prior to the first day of symptoms. So they're shedding a lot of virus before they even had symptoms. So we can acquire influenza and have no symptoms and shed it. We can have minimal symptoms, shed it. We can have cold-like symptoms and be shedding it even a day prior to our symptoms. So even if we were good enough to stay home with our upper respiratory infection, we may be shedding it for a day prior. So fact number 4, healthcare worker influenza and COVID-19 immunization protects both the worker and the patients. This is a cumulative analysis of a whole bunch of studies looking at trivalent vaccine efficacy of influenza in adults. And overall, it's about 55% protected. It's not a great vaccine, but it's something. 55% protection against PCR confirmed, 59% reduction overall in PCR confirmed symptomatic influenza infection. It's something. It's still something. Lots of studies show that a more vaccinated workforce shows up to work more, less absenteeism. You'll save about $2.50 for every $1 you spend on the flu vaccine program. What about the COVID vaccine? What's the current status of vaccine necessity and efficacy? It's a harder sell. Obviously, most of us aren't taking this vaccine. Nearly, and we got to admit, nearly all the population has some degree of immunity to SARS-CoV-2. Over 97% of people had antibodies of one form or another by the fall of 2022, either from the virus or the vaccine or both. We know that morbidity and mortality have been markedly reduced due to less virulent strains circulating now and baseline cross-protective immunity from our prior infections and vaccines. We also know that the mRNA vaccine efficacy is limited due to rapid waning of immune response, changing variants, and overall less morbidity. Even so, the 2023 monovalent XBB 1.5 vaccine protected about 60% against symptomatic SARS-CoV-2 infection and about 49% against the next strain that came out, JN1, which is now the current vaccine strain. And now this JN1 is gone, there's a new strain circulating, but it still maintains some cross protection against that next strain. These vaccines still had pretty good protection for particularly the vulnerable with this, which is mainly the elderly and people with comorbid conditions, about 50% protection against hospitalization, 67% against critical illness. I got to finish here. I'm going to go to, these are a bunch of slides that show the more you vaccinate your healthcare workforce, the better off the patients are. And I'll focus on these studies here, and particularly this one. This looked at a whole bunch of nursing homes that were randomized to get a big vaccine push for the flu vaccine, showed that the more they vaccinated the long-term care residents, it didn't make much difference on mortality. Those are the prior two slides. But when they vaccinated that workforce, when they got a higher rate of vaccines in the workforce, this is the, I'm going to pass this off here. This showed no benefit to getting more vaccines in patients. But when they vaccinated that workforce, they had abysmal vaccine rates. Only 7% of their long-term care workforce were vaccinated. With their big campaign, they got that up to 53%. But what it did to resident mortality is it brought mortality of the residents down by 42%. So vaccinating the residents really didn't drop mortality. I mean, we want to do it. We do it. We push for it. But vaccinating that, even getting up to just half the workforce in those long-term care facilities, this was a randomized trial, dropped resident mortality by 42%. Kind of putting this all together, you can reduce with flu vaccine about 88% infections. You can reduce sick days by about 28%. You can reduce days lost from work by about 41% and patient mortality by about 41%. Last, kind of wrapping up here, knowledge check. Which of the following best describes the impact of healthcare worker vaccination on the prevention of nosocomial or hospital-acquired infections? Vaccinating healthcare workers has no significant effect on the transmission of infectious diseases in healthcare settings. B, vaccination of healthcare workers works primarily, protects only the workers themselves, not really the patients. C, healthcare worker vaccination significantly reduces the risk of transmitting vaccine-preventable diseases to vulnerable patients, thereby lowering rates of hospital-acquired infections or facility-acquired infections. Or D, only patients need to be vaccinated. Hopefully you got from all of this. The correct answer is C. We really can impact our residents and patients when we boost up our rates of vaccination. The last fact I would say is influenza and COVID vaccines are safe. You may kind of question that. I encourage you to go to another talk we've done on this. How do we know vaccines are safe? That's available out on YouTube. I go into a kind of in-depth look at how we assess vaccine safety. And I'll just finish with this kind of thought. In the context of a communicable disease that might reasonably be spread by a healthcare worker who cares for the sick, frail, elderly, immunosuppressed, is that language of personal autonomy appropriate? My body, my choice. Is it only about us and that choice? And I hope you can at least kind of reflect with me on this, that it may be more than just that. And I'll finish with a quote from William Mayo, who was very much pushed the idea that the needs of the patient come first. We as healthcare workers put our needs and our wishes and our desires and even risks to ourselves second to the interests of our patients.
Thank you so much, Dr. Carson, for this incredible presentation. I was thinking for the recording, we could at least do a few, and if people need to take up. Okay.
Yeah.
I'll just start to go in order then that we received some.
I think I can see them. Do you want me to just kind of say them?
Oh, sure.
So, yeah. First one, I'm concerned about what's happening at CDC. The ACIP, as many of you may have seen in the news, the 16 or 17 members of the ACIP were all kind of removed from the CDC. How do we ensure that vaccines are still required, recommended based on sound science? We're in uncharted territory. I do not know the answer to this. A new group was appointed. I think a number of us have some concerns about some of the people that were put on that group, but we'll see. We'll see what happens and we'll see what they do. I think, since this is an advisory group, I think we can realize that like you can take or leave that advice, of the new group. And I strongly suspect that other professional societies are likely to step up to help, give advice, from another source that may be seen as, credible, like the Infectious Disease Society of America or the American Academy of Pediatrics. I suspect we'll see these other professional societies making similar recommendations. It may have more impacts on what vaccines are paid for and what's accessible through the Vaccines for Children program, because it's the ACIP recommendations that determine which of those are paid for. That is, I think, a substantial concern, and we'll see what happens. A friend and colleague of mine, Dr. Cieslak, asked me, he comes on these and he gives me these impossible questions. Dr. Carson, the high cost of typical public health follow-up of measles cases, I have to ask, is it worth it? Is all that contact tracing and follow-up reasonable expenditure of public health resources for the number of cases averted? I think it's a very fair question. Dr. Cieslak would know this better than me. He directs a public health state entity and is much more in the thick of this. I think we saw, I think if we go back and look at, I hate to say this, but I think if we go back and look at like, what did we do with COVID pandemic, with that one, with all our contact tracing, I'm not sure, how much we really prevented at all with all those, tons and tons of people we had working on this. But we were building the plane as we were flying it there. I think with the measles epidemic, I think a major focus needs to be on healthcare facilities having rapid recognition and ability to respond and take people, so they're not exposing people in the healthcare setting. That's I think a major should be a major focus and efforts of public health. I do wonder myself, well, and I'll back up a second. So I'll push back a little bit on what you're saying, in that all of that was pertaining to healthcare facility costs. And I think if you've got, if you've got a person in an ER waiting room or a pediatric clinic office waiting room, and you're having to ask the question, you've got an infant who is susceptible in that room, or an immunosuppressed person in the lobby of the ER, and there's a death from it. These get to be very, very thorny questions. How much expenditure to prevent death? Now, I think in the general public, like, you were out in Walmart or you were out at the, fairgrounds or somebody kind of walking around, there's probably a good question to be had there on how much we're averting. But I think for those healthcare settings, it's a pretty big deal. That would be my comment on that. Is the Tdap not recommended every 10 years? I thought protective immunity waned about every 4 to 5 years. I don't think the recommendation has changed. So you are correct that it wanes. As it stands right now, I believe it's just for the general population and healthcare workers, non-pregnant, it's a one-time dose. That's probably regularly being thought about whether it should be more than that. But you are correct, it wanes. The problem is are we going to give people a booster every 4 years, who are in healthcare? My hope is that a better vaccine comes along, and I suspect there are some in the works. Question about why do smokers have risk factor for poor immune response to the hepatitis B series? I don't know. I suspect it may be direct effects of, tar, nicotine, or whatever on immune cells, but I don't know. It's a great question. I don't know the answer to that. Is recommendation for HEPLISAV-B if a non-responder after a fourth booster dose? And no, I don't know. So the question is HEPLISAV an official ACIP recommendation? No, I'm inserting my own kind of thoughts there. It does mount a better immune response. It's a 2-dose series. If I were a non-responder, I would probably request or want the HEPLISAV, but I think the formal recommendations is either repeat the 3-dose series or get the 2-dose HEPLISAV series. So it's not to my knowledge, I don't think it's preferred by the ACIP. Either are acceptable. Another question, isn't Tdap recommended every 10 years? No, a tetanus booster is recommended every 10 years. The Tdap, which has a tetanus booster component, is only recommended once. Another question, since pertussis protection wanes and tetanus boosters are recommended to be up to date within 5 years, If an injury occurs, why haven't recommendations just changed to having a Tdap every 5 years? Kind of answer that. I don't know. And if somebody else knows more about this that's on here and might want to take a step, I don't know if Dr. Newman or Kylie or somebody knows why that hasn't happened, because it seems like a reasonable thing to suggest, like, let's just get a Tdap booster. Is there any downside? And I don't think there is a downside. Do you know, Dr. Newman or Kylie,
I
why
know the CDC language does say one dose, as you're saying, of Tdap, but then it says every 10 years you can get a TB or Tdap. So
either one?
mhm.
Yeah, okay.
I think most clinics have just chose to stock Tdap, and that is the preferred one that's given.
Right. One of the questions here is how efficacious is pertussis vaccine at preventing spread of disease? Do we have good evidence that cocooning, that's a great word that I didn't bring up, is effective? I will confess, I don't know of sort of direct studies on this personally. So I won't go so far as to say we know it's efficacious at preventing spread. And might you have, the ability to be infected and transmit without getting real sick? That's possible. I do think there is evidence that cocooning is effective. And that's probably because when you give that vaccine around a pregnancy, so we cocoon that newborn infant, you're trying to have mom pass on antibodies to baby. I'm a new grandparent, I'm due for my Tdap booster with my new grandchildren. We want to cocoon that baby by having everybody in their immediate sphere of influence get immunized. The vaccine is pretty good for 1, 2, 3, maybe 4 years. And so while they're in that most vulnerable period, you're much less likely, I think, to be infected. And if you're not infected, you're not likely to transmit. I'm glad for the question. I don't have off the top of my head like the data that I'd like to have for you, but I strongly suspect that cocooning those infants is effective. And then I think that was the same question there. Why isn't, tetanus is recommended every 10 years, not Tdap? Dr. Newman kind of addressed that. I think that's all of the questions. So again, sorry we went over here by about 15 minutes. I'm glad for those who kind of still stuck with us. There's still quite a few of them there.
There are a few that peppered in the chat, but I know we're well over time if we just want to call it good. Or I'm happy to ask you those if you'd like.
People want to stay on, I'll try. Yeah,
one would be, do you have good language to use for individuals who have had a complete MMR series, but if a blood titer is drawn and shows not immune, why they don't need a booster versus how we treat Hep B? And then there was a follow-up there. I don't know if you want to take that
those
one.
So I think you're kind of saying two probably exclusive things there. If you have evidence that you've got a 2-dose vaccine series of measles, you're probably not going to get a titer checked. Those people aren't, it's one or the other. You get a titer or you have documentation of a 2-dose series. We don't check. Are we talking about measles, mumps, rubella here? Was that the question, or hepatitis B?
MMR, yes.
MMR, yeah. So it's really kind of one or the other. I don't think we, have data or knowledge of like somebody who got a 2-dose series and got a titer. We just don't check. We presume they're immune because we know from past studies about 98% of those people are going to be responders and appear to have lifelong protection. It is very unusual to see someone who's fully vaccinated get it. It happens. It does happen, but a lot of times we don't know if those people are responders. So it's really kind of one or the other. You wouldn't have that kind of a situation to have the language to say you got a 2-dose series. Oh, you have a negative titer. Here's why you need a booster. It's really one of the, if you don't have the proof and you get a titer and you're negative, you can't be presumed to be protected. You need to get a repeat series.
Okay, thank you. Maybe we'll just have this be the last one. Is birth before 1957 for immunity for mumps and rubella not acceptable for healthcare workers, or do I have that wrong? Is that only for me?
No, I think that is, let me just double check that. I think that is acceptable. Let's see if I've got that here. Double check that criteria. Mumps. Let's put that one up. Documentation of 2 doses of the live virus vaccine, 1 for rubella, birth before 57 for rubella and mumps, not varicella. So yes, it is acceptable.
Okay, great. Well, thank you for sticking around a little bit longer here, and thank you for everyone for joining us today. We look forward to seeing you again at our next webinar. Have a great week, everyone.
Thanks, everybody.
Thank you for watching the recording of It Starts With Us, Why Healthcare Worker Immunization Matters, presented by Dr. Paul Carson on July 16th, 2025. For those seeking CPE credit for watching this webinar, and for clarification, this is only for pharmacists and pharmacy technicians, please follow the details on the screen.